Okay, you should have control. Take over.
Okay, sounds good. Well, thank you guys for having me here today. I appreciate that. And I'd like to talk about one of my favorite topics, which is anxiety. Now, this topic is we're not going to talk about how to differentiate between other diseases and anxiety. I think each practitioner has his or her way of doing that. What we're going to do is assume the diagnosis of anxiety and go through the pathophysiological processes and apply an integrative approach to dealing with anxiety. So when moving on, and I'm hoping I can control my screen here now, and move on to the next slide. And Stacy, I'm having a bit of a trouble here moving on to the next slide. Okay, there we go. Talking about the epidemiology of anxiety. According to the Journal of Clinical Psychiatry, it's the most common psychiatric disorder. It affects about 15 to 17 million citizens annually, depending on which source you get that from. Just note that 30% seek treatment, and most of those seek treatment from their general practitioners because there's still a stigma attached with going to see a psychiatrist. So you will be seeing a fair amount of anxiety in your practice. And this slide is a little bit slower than I would like it to be. Okay, so what is anxiety? Well, to simply state, anxiety is the persistent fear response without an identifiable trigger. Or if there is a trigger, then the response is in excess to what the trigger is. It primarily starts a fight or flight response. The Journal of Cardiology tells us that it increases our risk of inflammatory disease, cardiovascular disease, sudden cardiac deaths. And we know from personal experience, most of us, that it definitely makes us more prone to mistakes and makes us less productive as well. Now, we know that there's a genetic component to anxiety. We know that family members who have, for example, parents that suffer from anxiety or other psychiatric disorders are more prone to suffer from anxiety. But genetically, we're actually finding some genes that does that as well. For example, the Aurora gene is tied to post-traumatic stress disorder. This gene, its primary function is to protect the brain. And when we see variants in this gene, then we notice that some people are more prone to post-traumatic stress disorders. We also look at the gene for the brain-derived neurotrophic factor, which we'll look at later on in the talk. And just one switch of one amino acid can make us more prone to developing anxiety disorders. So what are the mediators of anxiety? I like to call it the big syndrome. It basically stands for brain, which is the neuroendocrine part of it, the immune system, and the gut. They all play a significant role in this system. They all intercommunicate between each other. For example, the vagus nerve connects the gut to the brain, and I like to refer to that as a super information highway. So what is happening in anxiety exactly? Well, first what happens is the trigger comes in, and what we have, that's sensory information. It comes in and it actually arrives into the thalamic area, which is the sensory part of the brain. And then that it subsequently follows two different pathways. One is the short route, and it goes to, and the other is a longer route. It's a parallel pathway. So we have the reflexive pathway, which is the amygdala pathway, and that pathway then sends the message to the locus coeruleus, which is the primary neuroepinephrine maker in the brain. And then that activates the sympathetic system, or the HPA axis, and that also communicates with the prefrontal lobe as well. So initially what's happening is that if we're in danger, we're having a fast way to respond to it. If the danger is not as immediate, it goes to the prefrontal lobe, which is the cognitive lobe, and says, hey, you know what, this is not as dangerous as you thought it was, so you have some time to respond to it. And this particular pathway, what we see is the activation of the HPA system. So we have the trigger goes to the amygdala, which then goes to the locus coeruleus, secretes neuroepinephrine, goes to the hypothalamus, which gives us the corticotropin hormone, which goes then to stimulate to the pituitary, which then goes to the adrenal gland, and that's how we get the fight or flight response. Now, the amygdala, we're going to look at each one separately. The amygdala is what we call the source of fear memories of the brain. So it's associated with fear learning. It's basically, again, drives our automatic reflexive learning. For example, a startle response, if you get shocked, you want to pull away from it immediately. That's where the amygdala comes in. Again, it communicates with the locus coeruleus, activates the HPA axis, which then activates the sympathetic system. So many times we're noticing that anything that affects the amygdala can affect our response to anxiety. It is a little bit more information. It's located in the temporal lobe. And again, it stores the fear memories. And it is activated by the receptor called the NMDA receptor. That's the N-methyl-D-aspartate receptor. That is primarily activated by glutamate, which we'll talk about a little bit later on. The interesting thing about the amygdala is not only is it important in learning fear, it's also important in unlearning that behavior. So it's the extinction of fear can also happen in the amygdala as well. Now we're getting to the locus coeruleus, which is the next part of this system. It's located in the brainstem, and it's responsible for our arousal state. And it communicates with all parts of the brain. Now we are told that, and of course we talked about it secretes norepinephrine, and we know that norepinephrine has a role in increasing our risk for hypertension, diabetes, and of course anxiety response. Now in the awake phase, when we awake, the locus coeruleus is activated. When we're in REM sleep, the locus coeruleus is asleep. In the awake state, in the phasic state, this is what's happening. There's a low level of firing of the locus coeruleus. When there's a stimuli, something that comes in of interest, then there's a spike in that firing, and then we're able to focus on the new thing that came in. During the anxiety stage, we're in what's called a tonic state. What that means is that there's a high level of firing in the locus coeruleus, so we are paying attention to everything. So if there's anything new that happens, we're not able to focus as well on that. So I summarize that is that if you're paying attention to everything, then you can't focus on anything. And so that's usually what happens at that point. When it's in the tonic stage, you're more prone to errors, and you respond more to distractions because everything is important. Okay. Now, when we're talking about the brain connection, we also know that there are neurotransmitters that are at play here. For example, GABA, serotonin, norepinephrine, and glutamate. We know that the HPA axis gets activated, and we know inflammation plays a role in this as well. Inflammation can activate the HPA axis. Inflammation can activate the amygdala as well. This PowerPoint is very slow, people. Okay, so when we get to the brain connection, we're talking about the neurotransmitters. There are 5 neurotransmitters implicated in anxiety. It doesn't mean that there are no other ones involved. It just seems to be the major players that we're talking about. We're talking about the GABA neurotransmitter, norepinephrine, serotonin, glutamate, and even though this is not a neurotransmitter per se, we cannot leave out the NMDA receptors. Now, let's talk about serotonin for a moment. Serotonin is known as an inhibitory neurotransmitter, and it's derived from the amino acid tryptophan, which most of us are familiar with. The majority of it is made in the gut, and the rest of it we'll find it in the brain and in the platelets. Now, serotonin does help with gut motility, and many times when we have constipation, IBS symptoms, we will use medications that are serotonin-based. Most of the serotonin in the gut is bound up. I believe, in my opinion, that serotonin is part of the defensive mechanism of each particular animal. And one of the ways to see that is that when we have a toxin that comes in, whether it's a food toxin or some other noxious toxin that comes into the gut, what it does is stimulates the release of all the serotonin, which then leads to explosive diarrhea, which the goal is to get rid of that toxin. Again, part of our defense mechanism. So here I'm going to look at serotonin a little bit more in detail. We see that serotonin can go to two different pathways here. It forms, tryptophan goes to two different pathways. It forms serotonin, and which then subsequently goes to melatonin. But it also goes through another pathway. And depending on the inflammatory status in our body will depend on which pathway is more pronounced. Now, as a general rule, most of serotonin will go through the other process. Where it is formed, you will see here the quinoleic acid and the kynurenine. These are inflammatory substances. If you look here, you will see that things that can stimulate the formation of these inflammatory substances are cortisol and the inflammatory cytokines such as the interferon gamma, tumor necrosis factor alpha, and the other inflammatory cytokines that you see there. So basically what we see is that inflammation, I know sometimes we use 5-HTP, for example, or tryptophan in order to enhance serotonin levels in an individual to not only improve depression symptoms, but also decrease anxiety symptoms. Sometimes what I have found in my practice actually is that sometimes has the opposite effect. And many times it is linked to that person being in an inflamed state. So many times we need to correct that first before we are able to use this particular nutrient for anxiety. Okay. Now, we know that serotonin plays a role in anxiety because studies tell us that when it's depleted in the prefrontal cortex, it leads to anxiety symptoms. We also know that serotonin has about 7 different types of receptors. It seems that the 5-HT1A receptor is the one that's most targeted in drug therapies. The 5-HT3 receptor is, again, stimulated by excessive serotonin, which then induces nausea and vomiting. When we talk about a serotonin syndrome, for example, that's one of the things that can happen, and serotonin syndrome actually many times looks a lot like anxiety. So what we're finding out in the brain through several research studies is that low amounts of serotonin can cause anxiety symptoms, but high amounts of serotonin can do the same thing as well. Then we're on to GABA, which is one of my favorite neurotransmitters, a major inhibitory neurotransmitter in the brain. And that, of course, is also found in the gut as well. GABA is actually what regulates the amygdala and to help to treat anxiety symptoms. And we're aware of this because we know that many times we are given, we give our patients benzodiazepines such as Xanax and Valium, etc., in order to alleviate some of the anxiety symptoms, and that's how these are thought to work. The way that GABA is made, it is converted from the amino acid glutamine, which then goes to glutamate, which then goes to GABA. So we have the glutamate decarboxylase, which does this. So if you are hung up, for example, if you're unable, because the glutamate to GABA is very dependent on vitamin B6, for example. So sometimes when there's a vitamin B6 deficiency, we can have a GABA deficiency. One of the classic examples of this, in my opinion, is when somebody is poisoned with the TB drug that actually poisons this pathway. How do we treat that? We treat that actually with large amounts of IV vitamin B6. Then we are looking, this is just a brief conversion of how glutamine gets to GABA. On the GABA receptors, again, we're finding that different types of receptors, and we're finding that most of the activity happens in the GABA-A receptors. And the net effect is that by affecting the GABA-A and the B receptors, then you decrease excitability. Then we get to glutamate. It's the most abundant excitatory neurotransmitter in the brain. Several studies are showing that if you can actually modulate these glutamate receptors or the NMDA receptors, we'll find out that we can improve anxiety. The only issue with that is that many of the drugs that are able to do that come with significant side effects. So we're looking for other ways to do that. One of the things that we know about the glial cells in the brain, So if the glial cells in the brain malfunction, we can get buildup of glutamate levels because the glial cells in the brain are responsible for removal of glutamate. Again, we talked about if we get dysfunction of the GAD enzymes, we can get a buildup of glutamate, for example. Interestingly enough, what we've heard of arachidonic acid, that seems to be able to block the glial cells from reuptaking glutamate, and that can also lead to glutamate toxicity as well. Okay, so glutamate works through the NMDA receptors, and it requires glutamine and glycine and a voltage in order to open the channels. Once the channels are open, calcium goes in. Calcium then makes some changes on the nucleus level, and then we get transcriptions for other things. Now, when calcium goes in, it can cause neuronal injury, and it can cause increased excitability as well. Now, the important thing about the NMDA receptors is that they're important in learning. So it's not that we don't need glutamate or we don't need the NMDA receptors. It's important. It's just that when it's overexcited, when there's an overabundance of glutamate, when there's an overstimulation of these receptors, that's when we run into the anxiety type problems. Now, talking about neuroepinephrine, interestingly enough, we just heard that neuroepinephrine comes from the locus coeruleus. And it can activate the HPA axis via its connection with the hypothalamus. The function of neuroepinephrine is that it actually facilitates and modulates the physiological response to stress. So some of us respond to stress by becoming less exploratory. We take less chances. We just don't stick our heads out as much. Other things cause us to respond to stress by actively burying ourselves, like an ostrich, for example. Both of those responses are mediated by neuroepinephrine. Now, there are other substances in the brain that can also have an effect on anxiety as well. Cholecystokinin, for example. When studies are being done with anxiety, many times we're injected, we use cholecystokinin to stimulate anxiety response. The thing we do know about cholecystokinin is that it is primarily known for its function to contract the gallbladder. So again, we have another gut-brain connection. Another substance we talked about was the brain-derived neurotrophic factor, BDNF. It's responsible for the health, growth, and plasticity of the nerves. So it helps the nerves to adapt to changes. It also helps to keep them healthy. Studies are showing, interestingly enough, that it seems to also help anti-anxiety meds work better, antidepressive meds work better as well. It protects cells from overstimulation from glutamate toxicity, which is very important. Other things that have been looked at for anxiety is oxytocin, for its role in social phobias. There's several studies that suggest a positive effect with that as well. So looking at the human studies we alluded to a little bit before, we see that in human studies, more individuals with lower BDNF levels, they're depressed. Now, and we see that the lowest levels, they did not respond to antidepressant treatment as well. Now, I know we're talking about anxiety, but be aware that anxiety and depression many times go hand in hand. Several studies show that when we're able to increase the BDNF, we're actually able to help antidepressants to work a little bit better as well. Now we're looking at the immune system connection. Several studies were done to look at this. One was inducing an inflammation infection in the gut and inducing increases in cytokines, and it was noted that anxiety behavior increased with that. Now, we also know that the immune system and the neuroendocrine systems share many receptor sites, so it's not a surprise that they interact with each other and affect each other as well. We know that cytokines can activate the HPA axis in and of themselves. We know that glial cells can produce cytokines de novo, and again, that can activate the HPA axis. And we know that it can activate the amygdala as well. So the immune system, when it's triggered, it produces some inflammatory, pro-inflammatory cytokines, such as the interleukin-6 that we're seeing here, IL-1, interferon gamma, tumor necrotic alpha. These cytokines can cross the blood-brain barrier, but they also can be produced de novo in the brain as well. And it's been shown that excess of, for example, IL-6 can act on neurons and increase anxiety and cognitive defects. Now, the immune system, when it activates the HPA axis, we get the same cascade that we got before. It increases CRH. Interestingly enough, this corticotropin actually sensitizes the cells, so it facilitates the action of the inflammatory cytokine, so it makes it easier for them to hyperstimulate the cells. The tumor necrosis factor was injected directly into the amygdala, and it showed that immediately it simulated the anxiety. Then an inhibitor of the corticotropin receptor was used, and that decreased the anxiety response, once again showing that anxiety is very tied to inflammation. Now, the other thing that we talked about when we looked at tryptophan, we saw that the pro-inflammatory cytokines can stimulate the formation of these inflammatory substances from tryptophan by increasing the IDO enzymes. We also, a word of caution here is that estradiol seems to be able to do the same thing as well, and seems to be a factor in autoimmunity. As we get older, lucky us, what's happening then is our inflammatory cytokines seem to naturally increase. When they increase, they can dysregulate that feedback mechanism, therefore increasing cortisol levels. And we have already shown that cortisol then can shift the metabolism of tryptophan over to an inflammation. So this is one of the theories why we think elderly people seem to be more prone to anxiety and depression. Now, for example, it was shown that SSRIs and tricyclic antidepressants actually have an anti-inflammatory effect. They were actually shown to decrease pro-inflammatory cytokines. And it's now thought that maybe that's one of the mechanisms by which they work. Initially, it was thought primarily that they just increase neurotransmitters, but looking at this is seeing that they also decrease pro-inflammatory cytokines. And one theory is that they seem to affect the neurotransmitter levels relatively immediately within the first 2 weeks or so, but they take longer to affect the cytokine levels, and that seems to coincide with just about the time that they take effect, which is about 4 to 6 weeks. Now, when we're looking at the gut connection, we know that the gut has over 1 million neurons. We know that 90% of these neurons seem to have a connection with the brain, and we already talked about most of the serotonin being in the gut, so we see we've got a mini nervous system going on here as well. Now, studies are showing that when you change a bacterial flora in the mice, you change the behavior of the mice. What they did was they had a germ-free mouse. They introduced bacteria from a mouse that suffered from anxiety, and immediately anxiety symptoms started manifesting themselves. Another way that they looked at this is that the anxious mice were treated with antibiotics. There was anxiety reduction as soon as the antibiotics were removed. Anxiety returned as well. So when we're looking at the brain-derived neurotrophic factor, which has been change in that has been linked to anxiety, we are seeing that the bacterial flora may actually have an effect on this particular transmitter in the brain. Some of the studies actually looked at it and saw that's what seemed to be what the bacteria affect, and it didn't actually change the cytokines. Then when they use Enbrel, for example, and we know Enbrel is an immune suppressant, it did decrease the cytokine, it did improve anxiety, but it did not do anything with the BNDF. So we see what we have is multiple ways to affect anxiety. Another study using this particular bacteria, the rhamnosus bacteria, was noted to augment GABA function in the brain via the vagus nerve. For example, when the vagus nerve was when there was a vagotomy, the anxiolytic effects was completely lost. The interesting thing was this bacteria was also shown to lower the cortisol level in the mouse as well. Another study that points to this is that using the longum bacteria after inducing infectious colitis, anxiety levels improved. When infectious colitis was induced, there was an increase in anxiety. When this particular probiotic was introduced, there was improvement in the anxiety symptoms. What, again, it was shown is that this particular bacteria increases the messenger RNA for the BDNF and subsequently, therefore, increased BDNF. But it did not affect the inflammatory cytokines. When you affect the inflammatory cytokines, you also seem to improve anxiety as well, but it does not affect the BDNF. Okay. Now, since we're saying here that inflammation can directly affect the flora of the gut and flora can affect behavior, could we think about food sensitivities and the inflammation that they cause in the gut, for example? They can increase cytokine levels. They can disrupt the immune system. So most likely, they can also generate an issue with anxiety as well. Now, for example, if I did I do the ALCAT testing on a lot of my anxiety patients, and I've also done the ALCAT testing on myself. I have to say I've noticed an improvement in bowel symptoms. When I'm treating anxiety, what I tend to do is look at everything, especially if somebody has significant gut system associated with anxiety, which is very, very common. Then what I want to do is try to address that component. So we're looking at gut and inflammation in one, and then address the brain component as well. There are actually some studies that show that stress contributed to the development of food allergies, surprise, surprise, and it increases gut permeability as well. With increase of gut permeability, we already know that that can stimulate the immune system and produce pro-inflammatory cytokines. One particular study looked at H. pylori, and that did the same thing in the gastric mucosa. So we get, once again, the activation of the immune system and cytokines. So part of the treatment is to remove the triggers. And if the trigger is bacterial, remove that. If it's a food, remove that. Then you heal the gut. Another bacteria that was shown to help with gut healing is this bacteria here, the Animalis lactis bacteria. Not only did it do that, it also decreased inflammation in the elderly and seemed to be able to suppress the inflammatory bacteria as well. So what now do we do? Well, just like we said, when possible, identify the trigger and remove it. If it's a food sensitivity, do an ALCAT testing, do a sensitivity testing. Get people on the foods that are not going to disrupt their stomach and intestinal lining. If there's an emotional trigger, try to identify that. And then consider probiotics. I almost put all of my anxiety patients on probiotics, and I'm very selective about the probiotics, of course, and I try to use the ones that were done in the study. Another thing is that many times you can check a cortisol level to see if that's playing a role here. Sometimes you can do a nutrient testing, such as urine organics. It can be suggestive of nutrient deficiencies, for example. It can be suggestive of gut imbalances, and it can be suggestive of neurotransmitter imbalances. Now, I tend not to depend on this test heavily for neurotransmitter imbalances, but it definitely gives me a heads up of if there might be possible nutrient deficiencies. Sometimes I could go ahead and do an arachidonic acid EPA ratio, that's the omega-3 ratio, to look at the level of arachidonic acid to see if that would be something that needs to be addressed. Could also consider looking at C-reactive protein, because studies show that there's a correlation between cytokines and increase in CRP, and also show that there's a correlation between activation of the NDMA receptors and increase in arachidonic acid. And then, of course, a stool sample if indicated. It will help you determine which one of these factors, and the answer you'll most likely get is that each factor is contributing something. So then what I tend to do then is to go on to check for some nutrient deficiencies like we talked about. And the next thing we do is go on to look to see if there are any herbal remedies that can be potentially helpful in improving some of the symptomatology. So many times I would look at checking the HPA axis and looking to things to help with the HPA axis, the inflammation, and the gut. So chamomile, for example, can actually be an anti-inflammatory, and it can possess some antimicrobial properties, and it also has this flavonoid that can actually help to regulate the NMDA receptor. So chamomile is a nice choice to choose for that. For inflammation, I tend to use like fish oil and turmeric, which have all been shown to be nice anti-inflammatory. Sometimes even resveratrol as well has been shown to be a nice anti-inflammatory. If that individual is overweight, I'll start them on a weight loss program because we know adipocytes can produce inflammatory substances as well. And I apologize because this slide system doesn't seem to be working, so I'm going to go ahead without it. There we go. The other thing is valerian has actually been shown. Many times we think that valerian is a GABA receptor agonist, but it seems to also help with regulating glutamate receptors as well. The jujube seems to, again, help with glutamate receptors as well. GABA has all sorts of studies on it, but it seems to enhance GABA receptors. We're not 100% sure of the mechanism of action. There's been some concern with liver concerns with liver toxicity with GABA, so I usually recommend that people work with a knowledgeable physician when using GABA, as there are certain parts of the plants that are usable and other parts that are not. Passion flower extract has also been shown to be helpful with GABA receptors. Now, we don't have to do all of these things. I'm just really going through the mechanisms of some of these things so that you will be able to make the choice yourself. Now, tryptophan, again, just remember we can use tryptophan, but it can have a potential flip side to it. So I usually check an inflammation before I go ahead and use tryptophan. Interestingly enough, St. John's wort, there's really no study that I've become aware of that seems to improve anxiety. It definitely does help with depression. It seems to have more of a tricyclic type of mechanism of action, but the studies doesn't really support in isolation using St. John's wort. Magnesium actually has been shown to modulate that NMDA receptor, and it's also, by doing so, it not only improves anxiety, but it improves cognitive behavioral therapy as well because it helps with the learning process. Vitamin B12, if deficient, I replace it because, once again, it protects the neurons from glutamate toxicity. L-theanine, love it, love it, love it, one of my favorite things to use. It seems to work on the GABA-A receptors, but it also seems to have an effect on serotonin and dopamine as well. Interestingly enough, I've noticed that in very few individuals it can stimulate a little bit of an anxiety response, and that may be because of its effect on dopamine. The good news about L-theanine, again, is also neuroprotective, and it actually decreases the formation of glutamate from glutamine. Lavender essential oil, the way this seems to work, and studies have looked into that, is that it seems to stimulate the parasympathetic nervous system to decrease excitability. There's an extract of lavender right now, I believe it's called silaxin. It's actually an oral form of lavender that's, when put head-to-head in a study, it seems to do as well as a benzodiazepine in relieving anxiety symptoms. We've got lemon balm, which actually is an inhibitor of the enzyme that clears away GABA. So that's the way lemon balm seems to work. It also seems to help the HPA axis a little bit as well. When we are talking about addressing the HPA axis, one of the most important things, of course, is stress management and cognitive therapy. Interestingly enough, this TB drug, d-cycloserine, has been used to augment cognitive therapy. It's not used continually. It's just used primarily before a therapy session directed at a specific phobia. In terms of the HPA axis, again, we know that magnesium helps, but the magnolia extract seems to help. Magnolol and the honokiol seems to help as well. It decreases the cortisol level in the mouse study that was done. It also seems to increase serotonin level in the hippocampus. It has a slight antimicrobial stint to it, and it also decreases the pro-inflammatory cytokines like tumor necrosis factor. And I've seen this one work really, really well, especially for people with sleep issues secondary to inflammation. If you've got a hormonal, if you suspect a hormonal component, then go ahead and look at some hormonal testing on these people as well. You can look at estrogen, progesterone, testosterone levels. All of these can contribute to anxiety if they're not in the proper amount. Interestingly enough, we know that estrogen can enhance the formation of serotonin. But estrogen in the inflammatory state also can enhance pro-inflammatory cytokines, so know your patient before using estrogen. Okay. The next step is that we're talking about, we already discussed that estrogen can increase serotonin levels. So what to do with the hormones? Again, if you suspect that your patient is very, very inflamed, then try to figure out where that information is coming from and calm it. If you suspect an autoimmunity, try to treat that as well before introducing hormones. That's my personal approach to it. We know that progesterone, of course, can have anxiolytic properties by the conversion to allopregnanolone. When it's taken especially orally, it seems to augment the GABA receptors, and that can definitely help with anxiety. We also know that progesterone can convert to cortisol as well, and I've seen it do that in some of my patients, and that starts to promote anxiety. So again, there's always a balance that's important. Pharmacologically, the first line of action is really suggested to use the SSRIs and to use the benzodiazepine sparingly because of their addictive potential, and I tend to agree with that. I think they're definitely designed for short-term usage, and what tends to happen is that we tend to keep them on for a little bit longer than they need to be on. So for example, the SSRI, we know Lexapro, lots of studies have been done on Lexapro with anxiety, and Bushbal, which particularly acts on the 5-HT1A receptors. Benzodiazepine, again, short-term. Beta blockers can block the sympathetic response to activation of the HPA axis. But know that beta blockers can sometimes contribute to anxiety, to depression as well in some susceptible individuals. So just be careful with your dosage on that. Some concerns with SSRI, we've seen that prolonged use can lead to osteoporosis. So just monitor your patients for that if you have them on long-term SSRI therapies, and do some nutritional augmentation to prevent that. What has been shown is that initially the SSRIs are very effective. However, with chronic use, the serotonin level actually gets lower than the initial baseline, and that's, quote, when they stop working. So there are you can do, so if you can do some nutritional support around that, you might find out you get better results. Things to avoid, and these are theoretical things that could potentially increase cytokines. So be careful if your patient is taking spirulina and you're seeing you're not seeing an improvement. You might want to ask them to stop that. Echinacea can potentially increase pro-inflammatory cytokines as well. Honey is a very theoretical one. I don't usually stop honey unless I really have to. Just remember that cytokines can stimulate the HPA axis. So if your patient is on something that's potentially stimulating the immune system, and that involves stimulating the pro-inflammatory cytokines, then you can have some issues with anxieties. Take your patient off caffeine if you can, gently, because it can block the receptors to adenosine. And adenosine is one of those chemicals in the body that can slow the heart rate and keep us calm as well. And caffeine blocks those receptors from working properly. And I believe that we are at the end of our presentation.
We are. Thank you so much, Dr. Harry. If anybody has any questions, please type them in the question box, and we will get to them as they come in. We'll just give people just a couple minutes to send in some questions.
Okay.
Okay, our first question is, it says, for older male patients, would you check hormone levels as well? Is there a link between anxiety and andropause?
There is a link between anxiety and andropause. There's a link between anxiety and lower testosterone levels. So for, yes, for elderly males, I would check their hormonal levels as well. That's not exclusive to females.
Okay. Next question, somebody asked, how about dark chocolate?
Dark chocolate and the magnesium content. I know is that the reference? Dark chocolate, depending on what's in it, I don't take away things like dark chocolate unless it's having an adverse effect on the patient. We know that cocoa can potentially have a small amount of stimulants in them where if somebody's super sensitive to it, they can respond negatively to that. But as a general rule, I don't take away dark chocolate. I don't use it as a treatment per se, but I don't take it away.
Okay. Next question, is there a greater relationship for food allergies causing leaky gut or vice versa?
Is there a greater, or does leaky gut cause, well, food allergies tend to cause leaky gut, and I don't think leaky gut, it can exacerbate food allergies, certainly, because then what you're doing is becoming more sensitive to more foods, the more damaged the lining of your gut is. And then you're producing more inflammatory cytokines, and you're producing more anxiety, and so you really need to stop that process. So we know benzodiazepines won't do that. They might calm the immediate anxiety-type symptoms, but they're not putting out the fire that's fueling the flame.
Thank you. Next question is, if you have a patient that has been on SSRIs for 10 years and has seen a decrease in its effectiveness, what would you add to either enhance their care?
Okay, if that patient's been on SSRIs for a very long time, one of the first things I do, actually, I didn't talk about this, I mentioned it briefly, is that I do neurotransmitter testing. I know there's some controversy about is it measuring the neurotransmitter in the brain, et cetera. What I have found is that it correlates pretty well with the clinical symptoms. So one, I want to avoid the serotonin syndrome. So a couple things I would consider is, for example, inositol. I know I did not mention inositol, but inositol has been shown to decrease anxiety and improve depression, and it does so by modulating the serotonin receptor. So it doesn't enhance serotonin per se, but it increases the effectiveness of the serotonin receptor. So one of the things I might do is start there, and then start adding some other things. And if there's no evidence of inflammation, then you certainly at this time you can try tryptophan, you can try 5-HTP. Inositol is just really well tolerated with SSRIs.
Thank you. And one last question that we have is, what would you suggest when you have a patient who's in closed-in places and anxiety sets in?
Yes, that's been in the open maze, and there's a lot of testing. So it sounds like when we're talking about that, it almost sounds like I'm getting a feel of almost like a panic attack at this point, as opposed to generalized anxiety disorder. Panic attacks are really a lot more extreme, as I'm sure most of us are aware. So that patient probably would need cognitive therapy to find out exactly, are they suffering from agoraphobia? What are they suffering from exactly? And if there's a specific phobia involved, then cognitive behavioral therapy seems to be very, very effective for that. Of course, we know that it's made more effective if you're doing things, whether that you use an SSRI or you use an herb or you use a nutrient. It seems to be more effective with that.
Thank you. Next question is GABA absorbed in the gut?
And that's a very good question, and there is some controversy about that as well. GABA is absorbed in the gut. The question is whether it crosses the blood-brain barrier once you've taken it orally. That's really the question. And most studies are suggesting it really doesn't do a good job doing that. I know there's some forms of GABA out there that have a particular different chemical base that starts to cross blood-brain barrier a little bit more effectively. I think some of it does cross, but not a lot. Pharma-GABA tends to cross a little bit more.
Okay. And the next question is, what herbal medicine do you recommend for estrogen?
Well, that really depends on what you're treating. Well, for example, there's a really nice study that was done recently with red clover. And if you're treating the anxiety-type symptoms and the insomnia that many times is accompanied with low estrogen, the red clover study has been shown to work really, really well with that. Interestingly enough, when you're looking at perimenopausal things and perimenopausal depression, anxiety, coupled with insomnia, St. John's wort worked really well here as well. I know many people use black gohash in combination with some maca, and for moderate climacteric symptoms, that seems to help many individuals. I think with estrogen therapy, it depends on how deficient they are, what kind of response you're going to get, and I have found many times that you need to combine herbs in order to get any effect. And with severe estrogen deficiency, it's usually a challenge.
Okay, thank you. That wraps up all of the questions that we've been asked. Just want to thank you again for giving tonight's webinar, Dr. Harry. The presentation has been recorded and it will be posted on the ALCAT website in the next couple of days. So if you'd like to refer back to it, you can, look there. Our website's www.alcat.com, and I think that about wraps it up tonight.
Okay, thank you, Stacy.
You're welcome. Have a good night.
You too.